Wonderful. Give me just a second to get settled here. All right. Well, good afternoon, everyone. Thanks again for joining us. For those of you who's joining online, I do tend to shuffle a little bit when I talk, and so I'll try to stay framed within the video. But I want to start off with this, is just by a raise of hands. I want to get a sense of where each of us are in our Parkinson's journey. And we use that word journey because, as you know, Parkinson's um, can be different at different stages of the progression. And so, could you raise your hand if you're kind of in the newly diagnosed 0 to 5 years mark? Okay, great, wonderful. And maybe from 5 to 10 years? Okay. And then for those of us who maybe have been with Parkinson's 10 years or greater. Wonderful. So maybe more of the in studio audience is more towards the 0 to 5 years. And my hope is to discuss management of Parkinson's, especially motor symptoms and the medications we use for motor symptoms along the disease progression. A lot of this information is going to be maybe very detailed, maybe too specific in scope, but I'm going to try to make it more practical and hopefully it'll be helpful to you all. So like Mike said, I'm Michael Shih. I'm the clinical pharmacist at the OHSU Parkinson Center. And like you said, I work alongside our providers at the clinic to help patients manage their medications, guide them through the intricacies of the medications, how to take it, what to do with side effects, how to manage the side effects. And then what happens if our symptoms change and we need to make a change to our medications. And so that's my role in the clinic. I spend most of my time face to face with patients, educating, guiding, and again, navigating through the complexities of the medications. And so today we're going to talk about therapies for motor symptoms of Parkinson's disease. We're going to have a lot of information to cover, so we're going to dive right in. We're going to dive right in. Maybe not. There we go. There we go. In terms of a disclosure, I have no actual or potential conflicts of interest in relation to this presentation. Our learning objectives are first, we're going to discuss the motor symptom therapies and their serious side effects. Some of these serious side effects are actually pretty common in between the different medications, and so we're going to dive into what they are, why do they occur, when do they occur, and who's at the greatest risk, and then maybe some management tips for those side effects. Second, we're going to define motor complications, and more specifically within those complications, the idea of motor fluctuations. And lastly, we're going to highlight some non-medication therapies. So, this is kind of the Parkinson's 101. What are the cardinal motor symptoms found in Parkinson's disease? Well, there's really 4 of them that we deal with here. The first is bradykinesia, and that's just the medical term for slowness in movement. So again, it's a generalized slowness of movement. Sometimes it goes unnoticed in the beginning of Parkinson's. You might find that you have decreased dexterity and some shuffling steps as you walk. This is actually the most common feature of Parkinson's disease. About 80 to almost all patients when they present with Parkinson's have some sort of bradykinesia. Again, it could be slight, so maybe not noticeable. It could be attributed to perhaps an old sports injury, old age, or things like that. But it is actually the most common. As opposed to tremor, which is kind of our characteristic Parkinson's symptoms that everyone really associates with Parkinson's. This tremor is characterized being at most severe at rest. It lessens upon action, so purposeful movement, reaching out and grabbing things. And it's oftentimes described as pill rolling, and that means that it involves the thumb and the finger in a rhythmic fashion, like you're rolling a pill between your thumb and your index finger. And this actually presents about 70 to 80% of patients when they get diagnosed with Parkinson's, so just a little less than that bradykinesia. The next cardinal motor symptom is rigidity, and this is defined as an increased resistance to passive movement. And so if you've ever been evaluated in the clinic, the physician or clinician might ask you to relax your arm and move your arm in a passive movement, and they might experience some rigidity or resistance to that movement. And that's what rigidity is, okay? And then lastly, instability. And instability is an impaired reflexes and a decreased ability to prevent falling. This oftentimes appears later in the course of the disease and is least responsive to the medications we're going to discuss here today. Great. So this slide here lists, and it's quite a busy slide, but it gives you an idea of all the medications used to treat motor symptoms in Parkinson's disease. When we talk about medications, they're often tools in a toolbox. That's the analogy that we use. And our toolbox is quite large here for motor symptoms. And when we talk about medications, we often group them into classes based on how they work in the body. And so I'll kind of list them out, but you'll see that some of them are quite repetitive. And so first we'll talk about dopamine agonists. And these medications that you might use in this group are called pramipexole, ropinirole, the rotigapine patch, and the apomorphine subcutaneous injection. Our next group would be the levodopa-containing medications. And you'll see that it's always kind of paired with carbidopa, and we'll talk about why here in a few minutes. But there's many different formulations of levodopa, going from an immediate release tablet to an extended release capsule to being able to inhale levodopa through an inhaler. Next, we'll talk about, we'll stop there and with the dopamine agonist and levodopa. These two classes together are oftentimes what we refer to as dopaminergic. And what that means is that they mimic dopamine in the body somehow. And so that's dopaminergic. And so if you hear me refer to dopaminergic or dopamine load later on in the presentation, I'm usually referring to the dosage of these two groups of medication. Next, we'll talk about a few classes of medications that work to amplify levodopa or dopamine in the body. And by amplify, I mean they tend to extend how long levodopa works in the body, or they block the premature metabolism of dopamine in the body. And so these include our COMT inhibitors, our MAOIB inhibitors, so these two groups are oftentimes what we call as our blockers, again, amplifying the action of levodopa in the body. Other medications that don't really fall into a specific class is amantadine. If you guys use amantadine or are familiar with amantadine, its mechanism of action is a little bit different, and we'll talk about why here in just a moment. And then lastly, our two drug classes are the anticholinergics and the adenosine receptor antagonist. So quite a few tools in the toolbox. And we're going to hone in on each of these, talking about how they work and what side effects we expect with each medication class. In just a moment. There we go. Okay, so this graphic here it's quite busy, but it's a wonderful graphic because it really starts to paint the picture of how these medications interact with the body. And so as a pharmacist, as a student coming up and doing my studies, the basis by which we understand medications, we have to understand, one, how does the body work normally? Two, what is the injury to the body that then causes the disease of discussion? And then three, that really lays the foundation for then how we understand medications, how they work, and what they do to move our body back to that homeostasis or that normal function. And so here, and I'll just orient you very quickly, on the very left is blood circulation. Now, medications, whenever we take them, no matter if it's through a pill, an injection, whatever, a patch, whatever it may be, that medication has to circulate through the blood and then travel to its site of action, and in this case, the brain. That partition you see is the blood-brain barrier, and it's exactly what you think it is. It's the barrier between the blood and the brain. Medications have to be formulated in a certain way to cross that barrier to be effective at the site of action. And in this case, again, it's the brain. Now, everything on the right-hand side, that is where the crux of the matter is. In Parkinson's disease, there is a loss of the neurons that store and release dopamine. And so this is kind of a depiction of two neurons and the connection between two neurons. The one on the left is the neuron that stores and releases dopamine. The one on the right is the one that receives the signal from dopamine and then cascades down to the motor symptoms that we have. And so when we lose the neurons that have dopamine, we tend to start having those tremors and the motor symptoms that we discussed in the previous slide. And so that is the foundation by which we will work on understanding our medications. And we had talked about dopaminergic medications, And so those medications mimic dopamine. So it's very easy. If you're lacking dopamine, why don't we give you some dopamine, right? And so those two drug classes mimic the action of dopamine in the body. Everything else tends to extend it or somehow amplify it so that it works longer and better, okay? And I know I've probably lost a few of you here, but we're going to hone in and we're going to take it step by step. And so it's clearer um, and better to understand. So again, lack of dopamine, dopamine travels from neuron to neuron, binds to that dopamine receptor, and that causes the symptoms or the action that we want. And so whenever we lose dopamine, there are two ways we can do it. We can either supplement the dopamine, or we can actually create a molecule that binds specifically to that receptor so that we get the action and the symptom relief that we want. And that is actually the first mechanism of these dopamine agonists. And so dopamine agonists are exactly what they are. They're a group of medication molecules that bind to the receptors of dopamine, allowing the cascading effect and the control of the tremor, the release of the bradykinesia, and the rigidity. Okay? And so the medications you might find in this drug class are called the ropinirole, pramipexole, rotigotine, and apomorphine. Again, they are a direct activation of the dopamine receptor, which release or allows symptom relief. In terms of administration, taking the medication orally, there's not really, it might be different between the different oral medications, but by far you can take with or without food. The common side effects that we find with the dopamine agonists are things like nausea, constipation, dizziness, somnolence, vivid dreams, or edema in the lower extremities. And edema is just kind of a swelling, fluid retention. The more serious side effects that we find with dopamine agonists, and there are quite a few, are things like sleep attacks, cognitive changes, hallucinations, impulse control disorder, and dyskinesia. We'll talk a little bit more about these serious side effects in the second here in the presentation. We'll kind of dive a little bit deeper into what these are and why they occur. But we will kind of see a pattern to emerge with the medications that the side effects might be very common between the different groups. We do have a question here in the studio.
Do you take questions along the way? That's
Sure,
the question.
absolutely. Sure. Oh, that was the question.
Yeah.
Okay, so the question is, do I take questions along the presentations? And the answer is yes. I did see another hand up, I think. No? Okay. So the question oftentimes is, oh, which medication fits best for which patient? And that can be, that relies on the expertise of your treating physician and clinician. But in general, and these are broad strokes, and it may not apply to each specific patient, but in broad strokes, the dopamine agonist can be used as monotherapy. Oftentimes in younger patients, and especially if they have a tremor prominent presentation upon diagnosis. And especially because of the serious side effects of the impulse control disorder, we want to make sure there's no history of novelty-seeking behavior before we start these medications as our first-line therapy. But again, it can be used as a monotherapy or adjunctively with other medications in our toolbox. So that's dopamine agonist. And again, that's just direct stimulation of the dopamine receptors to relieve the symptoms. Next, we'll talk about everyone's favorite medication, and that's levodopa. And levodopa, as you may have heard, is the backbone of treatment for Parkinson's disease. And we'll talk about why that is. But levodopa is what we call a precursor to dopamine. And that means that when someone takes levodopa, it naturally is converted in the body to dopamine. And that is a very kind of a line A to B sort of solution, right? If you're lacking dopamine, let's give you a medication that can be transformed into dopamine in your body. However, levodopa does have some issues, and we'll talk about why levodopa can be challenging as Parkinson's progresses. So again, levodopa mechanism is converted to dopamine. Some might ask, well, why can't we, instead of skipping the levodopa, waiting for the body to convert it from levodopa to dopamine, why can't we just give dopamine to a patient? Well, actually we do, and we can. Dopamine can be given intravenously or into your blood, but it cannot cross that blood-brain barrier. And so if we were to give you just dopamine, it honestly doesn't get to the site of action that we want. Dopamine given intravenously to patients is oftentimes in a critical care situation to help support their blood pressure, their heart rate, and the most critical of illnesses. But again, it can't cross that blood-brain barrier. Therefore, we have to make levodopa. In terms of administration and how to take levodopa, you have to separate it by protein-rich meals. And the reason for that is in the gut and in the intestine where medication gets absorbed, levodopa has to fight against protein for the same transporter from the gut to the blood. And so so if you were to take levodopa with protein, such as chicken, meat, beef, or even yogurt, dairy type of protein, it would interact in the gut and the intestines, making it so that the levodopa gets absorbed less. So what do? So we suggest to our patients that you take levodopa, separate it by your meals by about 30 minutes to an hour before, and then an hour after the meal. For the sake of just for it to make it easier, I tell patients separate the levodopa with your meals by an hour before and after. So you don't have to worry about was it 30 minutes after or 30 minutes before, or was it an hour after? Just think about it maybe an hour before, an hour after your meal. Separate your levodopa. Yes?
So if there's no protein in your meal, then is there an issue?
That's a wonderful question. So the question is, if there's no protein in my meal, do I have to worry about separating levodopa? Not really. What we suggest to patients who have that nausea, vomiting whenever they take levodopa, you can take it with carbohydrate-based foods such as crackers, toast, cereal, things like that. And really, that interaction really is just between levodopa and protein itself. Okay.
And I'm sorry.
Sure.
And so you would include salmon, other seafood.
Right.
So it's protein is protein, regardless of the
Protein is protein. The characterization of which one might be worse, it's kind of blurred a little bit, so we just advise protein is protein.
Michael, is everything divided into protein or not protein? Nothing else in between?
Right, so the interaction is mostly with just protein.
You mentioned carbs. With those else that wasn't a carb, but it's also okay. So anything
Sure.
that's not protein, it's okay.
Exactly.
Alcohol.
We'll talk about that offline. So side effects of levodopa that we find, the most common one, of course, is that nausea, vomiting, constipation, something called orthostatic hypotension. And that's just basically our blood pressure can drop when we go from a lying down sitting position to standing. And we find that blood sugar dips pretty significantly when we are on levodopa. Other serious side effects, and again, we're going to talk about these more in detail, are dyskinesia, the impulse control disorder, and hallucinations. Now, where does levodopa lie in the treatment spectrum? Who qualifies for levodopa? Almost all patients at some point in their disease will be started on levodopa, mostly because it's the most it's just the most familiar. It's the most straight A to B solution for giving dopamine to the body. Okay. Any questions here?
Oh, I have a question.
All right. So you may, if you do take levodopa, have noticed that it always has a sidekick with it. And the sidekick is called carbidopa. And what carbidopa does is it has to be paired with levodopa because it helps, again, increase or amplify the levodopa and how much of the levodopa can get into the brain. It also helps prevent the premature breakdown of levodopa that would cause certain toxic side effects, such as that nausea. And so how does carbidopa work? Again, it blocks the dopa decarboxylase enzyme that breaks down levodopa prematurely. And that's what you see here depicted on the left. That in the blood circulation, as levodopa travels from the blood to the brain, it can be prematurely metabolized, and carbidopa inhibits that premature metabolism, allowing more levodopa to reach the brain. You usually find that carbidopa is given in a 1-to-4 ratio, so 1 of carbidopa to 4 parts of levodopa. And in fact, for those of you interested in certain Parkinson's trivia, the word or the brand name for carbidopa levodopa is Cinnamate. Is anybody familiar with that name? So if you break down Sinemet into two words, sin, which is without, and emet, which is short for emesis, which is the medical term for nausea and vomiting, then it is without vomiting. So the addition of carbidopa to levodopa, that's how they came up with the brand name to address the side effect of the vomiting. So just a little bit of a trivia. We don't get much here in the Parkinson's world in terms of trivia. So I figured I'd share that one at least. So to depict what carbidopa really does with levodopa, this is a great graphic here. On the top is just if you were to give the body, and I'm so sorry it's cut off there by the toolbar, but at the very top, if you were to give levodopa by itself, let's say 100 milligrams, that's a very basic dose, about 70% of it would be metabolized in the GI tract and not absorbed. And then another 30% would be metabolized in the peripheral tissues or in the blood, as we kind of illustrated in that slide before. And that means only 1 to 3% of that 100 milligrams levodopa actually reaches the brain. And that's a very poor return on investment, if you ask me. Now, if we couple that with the carbidopa, we see a whole different picture. Now, only 40% gets metabolized in the GI tract, another 50 in the peripheral tissues, and 10% of that levodopa can now reach the brain where we want it to. So it's almost a tenfold increase in levodopa that gets transported over to the brain just by simply adding carbidopa. And so it really revolutionized, in a sense, how levodopa works in the body and how we provide it to our patients. Yes?
So what's the effect of it being metabolized in the body? That medication doing side effects from it being metabolized?
Yeah, exactly. So the main detriment is that you don't get levodopa to the part of the brain that you want it to provide the symptom relief. The other one is that when levodopa gets metabolized prematurely in the circulation, it can cause that significant nausea, resulting in the vomiting. And so that carbidopa, which is great transition, thank you so much, to my next point, is that carbidopa actually is available by itself, separate from levodopa, in the event a patient needs more or is experiencing the nausea and the vomiting and those side effects. Carbidopa can be, we can increase the amount of carbidopa outside of the combination pill to address that. Okay, so we're going to move on to our next drug class, and these are the COMT inhibitors. So what is COMT? COMT, again, is another type of enzyme that prematurely breaks down levodopa. So therefore, we block this premature metabolism by using these COMT inhibitors. And the medications under this drug class are things like entacapone, which many of you might be familiar with, opicapone, or tolcapone. And again, blocks the premature metabolism of levodopa, allowing more levodopa to reach the brain. It's used only adjunctively with levodopa. You rarely will ever see COMT inhibitors used by themselves. They are used adjunctively with levodopa for wearing off. And the studies and in the literature that we found is that with the addition of COMT inhibitors, they oftentimes can extend that on time, and that on time means good symptom control, good relief of the symptoms when you're taking levodopa by about 30 minutes to an hour. And that will come into play when we start talking about motor fluctuations and motor complications. Okay. Again, always given with carbidopa, levodopa, depending on which medication, oftentimes taken multiple times a day to 3 times a day, and with the opicapone, it can be taken once a day. Side effects with the COMT inhibitors are much like the ones we find with levodopa. Because it amplifies levodopa, it might amplify the risk of the side effects. And so nausea, vomiting, constipation, the hypotension we talked about, but more specifically with COMT inhibitors, you might experience some urine discoloration, which usually resolves upon discontinuation of the medication. And again, more serious things such as dyskinesias, hallucinations, impulse control disorder. And then specifically with tolcapone, we find that there's a risk of liver toxicity. Yes?
How often do people take levodopa? I was starting off at 3 times and then switched it to 4 and then back to 3. I have no idea how long it lasts.
Sure.
Whether it's wearing out.
Sure. That's a wonderful question. And the question for our online audience is, how often should levodopa be taken? Most oftentimes when we start with carbidopa levodopa, we titrate up to about 3 times a day, 1 tablet 3 times a day. And that's kind of a good baseline treatment. However, and we'll talk about this when we talk about motor fluctuations and complications, is that we start to pivot and balance between providing symptom relief and avoiding side effects. And we'll talk about how we do that, why we do that, when might a clinician or a treating provider consider making some changes. That's a great question.
You space that evenly throughout the day, I assume?
Yes, usually.
How about overnight?
So that's also a great consideration. And the question, again, for the online audience is how about overnight? When do we start taking or adjusting levodopa for overnight? I'm going to save that question for the portion of the discussion where we talk about motor fluctuations, and I think it'll be a better illustration at that point. Okay, so into our next drug class is called the MAO-B inhibitors. So MAO, yes.
Do you want to hold it?
You were saying earlier that tends an hour or so.
We find that in the literature and in the studies that we did for that drug class, that it tends to extend between each dosage of levodopa. The amplification effect that we've been talking about tends to extend the on time by about 30 minutes to an hour. Now, it's difficult, and I know Mike had mentioned this kind of in the beginning of the presentation, but I'll take a minute to address that too. Is each body is different, each person's journey in Parkinson's is different, and so it's hard to generalize, but it's also hard to know for sure how each body is going to react to each medication. And the reason that being is that through genetic makeup, through different what we call factors in absorption, metabolism, and things like that, and design of medication, to say that one thing happens for one patient will definitely occur for another patient, we can't say that. And so there's a lot of differences and a lot of personal adjustment and personalization to treatment that we do with Parkinson's.
Some Parkinson's is caused by genetics. Test DNA test to confirm that, and some is caused by environmental.
Right. So the question or the comment and for the online audience is that there's studies undergoing, and there are fascinating studies undergoing about the genetic aspect of Parkinson's, and it really is fascinating, and it's so interesting. Not really within the, I guess, purview of our presentation today, and in all honesty, not really in my wheelhouse either. But it is a great conversation to have, and fascinating research to be done. I believe there was.
So you mentioned it's on time and off time. So what does that really mean?
Perfect. And again, I think we're going to address that really well in an illustration later in the presentation. And for the online audience, the question was, what is on time, what is off time? And that's wonderful. We'll talk about that here in a couple of slides. So I'll try to get through these slides really quickly so we can get to some of the interesting stuff that I think you guys are itching to get to. This next drug class is the MAO-B inhibitors. Again, it's a drug class that includes medications such as misagiline, selegiline, and sulfonamide. And these prevent, again, another type of metabolism pathway for dopamine. And if we can inhibit these metabolism, then we can extend or increase the amount of dopamine that gets released. In terms of administration, the MAO-B inhibitors are very interesting. They come with a slew of drug-drug interactions. And so sometimes we don't reach for these medications very quickly due to the amount of drug-drug interactions, especially if patients have other chronic disease states that they're also taking medications for. Common side effects are things such as nausea, abdominal pain, decreased appetite, headache, and more serious ones specifically for this drug class is agitation and insomnia. And this is oftentimes found with the selegiline, and that's because selegiline, when it gets metabolized, um, is metabolized into an amphetamine, which can cause a sort of hyperactivity, and if taken too late in the day, can cause some pretty significant insomnia. So we suggest if patients are on selegiline, that we take them earlier in the day and avoid too close to bedtime. Okay, so for this graphic, our last one is amantadine. Now, amantadine has its mechanism of action is not clearly or entirely understood. There's some theories that it may enhance the release of dopamine at neurons. And what we found with amantadine is that it's good for tremor. It's great for dyskinesia. And dyskinesia, again, is a side effect of too much dopamine and dopaminergic load. And so, in terms of side effects for amantadine, we have something called lividio reticularis, which is a skin discoloration with a mottled type of characteristic, and it's due to the spasms of blood vessels right on the skin level. And this oftentimes resolves if we discontinue amantadine. Amantadine also has a side effect of insomnia, and so we oftentimes recommend to our patients to take this earlier in the day. So amantadine is great. It oftentimes is a medication that we reach for to treat the dyskinesia that can oftentimes be bothersome whenever we have to increase the amount of levodopa or other dopaminergic medications. Okay, so we've kind of got through that depiction in this graphic here. And it gives you just a sense of where does each medication target, and it helps us to understand a little bit about their mechanism of action. Now, I return to this page and our toolbox page because there's the last two classes of medications. I couldn't find a graphic that was simple enough. They got to be too complicated and a little too detailed. But those classes of medications are the anticholinergic class and the adenosine receptor antagonist. So for the anticholinergic, the reason why we use this medication class in Parkinson's disease is that when we find that there's a decrease in dopamine in the body, it's oftentimes coupled with an excessive amount of an enzyme called acetylcholine in the body. Acetylcholine is another neurotransmitter. When we have an excess of acetylcholine, it results in tremor and other motor disorder symptoms. And so we use the anticholinergics, as it sounds, to block the acetylcholine, restoring smooth movement and motor control. Now, the anticholinergic can be used as monotherapy, again, singular by itself, especially if a patient has tremor-dominant presentation. It's usually used in a younger population as the side effect profile of cognitive decline is quite burdensome. And so, again, the side effects such as it affects our cognition, our short-term memory, and it can cause things such as urinary retention, dry mouth, and things like that. Now, for the last drug class are the adenosine receptor antagonists, and this is kind of a unique medication in this unique class, and its mechanism is to block a certain receptor that when it gets activated, it works against dopamine in the body. So if we block that receptor, we allow dopamine to work unimpeded. And its side effects are things such as dyskinesia, changes in behavior and thinking, hallucinations. And this drug class is only used adjunctively to treat motor fluctuations. So I did want to hone in on some specific, more serious side effects to talk about them. And I've chosen 4 here that I think are of particular interest. First, we'll talk about dyskinesias, what they are, how to differentiate dyskinesias from your tremor. Next, we'll talk about impulse control disorder, what it is and how do we manage it. Next, we'll talk about hallucinations, and lastly, sleep attacks. So dyskinesia is oftentimes, one of the more common bothersome side effects that we have when it comes to using levodopa and dopamine agonists and our other medications for motor symptoms. And patients oftentimes have a difficult time differentiating between their tremor and dyskinesia. And the reason is that dyskinesia is also an uncontrollable movement, but it has certain characteristics that are different than tremor, and we'll walk through that. So tremor, again, is a common early symptom of Parkinson's, whereas dyskinesia tends to develop after years of someone taking medication. Some people may develop dyskinesia earlier, especially if they have to increase their levodopa quite quickly. So tremor is rhythmic, like we talked about. Again, that pill rolling, it follows a certain pattern. Tremor tends to lessen as we have purposeful actions, such as reaching out our hand. Dyskinesia is non-rhythmic. It's almost like a jerking type of movement, twisting, dance-like, and it can occur anywhere in the body. Dyskinesia is usually a peak dose effect, so when the medication is highest in your body, but it can be biphasic. And what we mean by that is it can occur, dyskinesia can occur at the highest dosage of drug levels in your body and at the end as the medication starts to wear off. About 40% of patients develop fluctuations in dyskinesias about 4 to 6 years on levodopa therapy. And there's an increased risk of developing dyskinesia if patients are earlier in age on their diagnosis of Parkinson's, and again, at higher levels and dosages of levodopa. Before I move on, any questions about dyskinesia? Okay. Yes.
Higher dosage, how many dosage are you talking about?
That depends on each different patient. Some might experience some at what might be, maybe 1 tablet 3 times a day. I've seen some patients have dyskinesia then. Not very common, or as high as, 2 tablets 5 to 6 times a day, things like that.
I've not had a diagnosis for 4 to 6 years, but I think I have dyskinesia prescription. That's still possible.
Right.
Most common application.
Exactly. And so that's always the tricky thing. When you come up here and you give a presentation, because everybody's different, that range oftentimes is wider or more narrow, dependent on each person's experience.
Okay.
So next, we're going to talk about impulse control disorder. And this oftentimes is maybe a little bit more touchy, awkward subject for patients, but I think it's very important because patients who are unaware that this is a side effect can be really caught off guard. And so what is impulse control disorder? It's kind of what it sounds like. A side effect of our medications is that there's less inhibition to compulsive spending, gambling, eating, increased libido or hypersexuality, and punding. And punding is the completing and uncompleting a task. So folding a blanket and then unfolding it, and then refolding the blanket and then unfolding it, or putting something together and then taking it apart and then putting it back together, and kind of that compulsion to do that task over and over and over again. So which medications are highest at risk for this side effect? What we found in the literature when we studied patients and the side effects that they experience, we find that the dopamine agonists actually have the highest risk of this impulse control disorder. Next would be levodopa. And by the spectrum of the impulse control disorder, can be as small as buying some extra trinkets here and there, to some patients, losing a lot of their retirement fund, a lot of their personal finances get ruined. And so there's a spectrum there, but the highest, it's always worth noting and being aware of the risk of impulse control disorders so that your loved ones, your family, your caregivers can help monitor for these big changes in behavior. So in terms of management, how would we address the treatment of a patient who is experiencing ICD? Well, first we decrease the dopaminergic load. Being a side effect of the medications, we would work to balance decreasing the amount of medications you have to take, hoping to still retain some of that symptom benefit, but avoiding the ICD. And then again, I cannot reiterate enough that involving your family members, your loved ones, your caregivers with helping to see any changes in behavior is paramount to the care of these patients. Okay, next we're gonna talk about hallucinations. So hallucinations it can occur with these medications used to treat motor symptoms of Parkinson's. And the reason why hallucinations might occur, and there's debate about the mechanism of how this happens, but there's a heightened reward and a dampened negative feedback. And again, that reduced inhibition when we take dopaminergic medications. And so, I'm sorry, I was on the wrong slide. There was a mixed picture there's a mixed picture for hallucinations. It could be either part of the progression of Parkinson's disease or as a side effect of the dopaminergic agents. And how do people characterize the hallucinations is oftentimes visual. And many patients say that in the beginning, when they start to have hallucinations, they might see something at the corner of their eye that really isn't there. Or they might see a trash can at the corner in the peripheral vision and think it's a dog. It's more times visual, and patients often retain what we call insight, and that means I know that that's not there. I know when I see that at the corner of my eye that that is a hallucination, and that's what we call insight. They're able to differentiate. Now, as things worsen and as hallucinations can progress, they can start to lose that insight, and that's when we start to consider specific medications to tackle the hallucinations. So, which medications can cause hallucinations? Again, the dopamine agonists are kind of our biggest culprit. In a large study of patients and the reported incidence of hallucinations, pramipexole kind of floated to the top of the barrel as having the highest risk. Next was ropinirole, and then last was levodopa. Now, how do we manage hallucinations? Oftentimes, if the hallucinations are not frightful, if they're not serious, and if the patient still retains insight, again, the ability to say, I know that's out of the corner of my eye, I know that's a hallucination, it doesn't bother me, then we oftentimes maybe don't treat it in those early stages. As things worsen, as the hallucinations become more vivid and more frightful, we'll decrease the dopamine load. We'll have family and caregivers again help monitor for those changes. And then at the very worst, we can start medications to tackle the hallucinations, specifically some antipsychotics. Okay, the last serious side effect that I really wanted to touch on was the sleep attacks. And the reason why is that sleep attacks oftentimes aren't really included in the discussion of side effects, but they can be quite detrimental to your health. And so sleep attacks are defined as the sudden onset of sleep during some sort of activity without any warning. So you could be driving, and all of a sudden, a patient with a sleep attack can fall asleep at the wheel. Or they could be handling heavy machinery or other some sort of power tools, and that can cause some serious bodily harm. And so the sleep attacks and why they occur, it's unclear. It's a mixed theories if this is solely due to the medication as a side effect, or is it also folded into the process of the degeneration of neurons in Parkinson's disease. So again, a mixed picture as with the hallucinations. But the prevalence is up to about 13%. And those patients who would take a combination of a dopamine agonist plus levodopa are at the highest risk, and then pramipexole, ropinirole, and levodopa carrying the lowest risk here. So how do we manage sleep attacks? Well, one, as a pharmacist, I would review your whole medication profile, making sure there's no other concomitant medications that you're taking that can amplify the effect of somnolence, fatigue, drowsiness, confusion. And if we can, we will work to reduce those concomitant medications. If that's not an option, then we'll reduce the dopaminergic load or even have to discontinue some medications if the sleep attacks are very severe. And as always, we ask that you have your family members, your loved ones, and caregivers to help monitor. And if you are starting these medications, we suggest taking things slowly, not operating or driving until your body can adjust and you're able to understand how that body will affect, the medication will affect your body. Okay, I'm going to pause here. Any questions about the side effects that we've discussed?
Why did you say the medication? And why is that a reason to quit?
Oh, no. So it's not necessarily a reason to quit. It is a side effect that we like to make patients aware of so they're not surprised when they find that the urine is discolored. If the medication is discontinued, we find that the urine discoloration also goes away.
So I haven't seen anything on her with anything affecting the vascular system whatsoever. Is that correct?
Yes.
Okay.
Okay. So one of the questions we oftentimes face is, when should we start medication? when we talked about each drug class, we kind of talked about briefly who would be appropriate to start those medications, but when should we start medications? And this is a very interesting question because the time of diagnosis of Parkinson's may not necessarily be the time when we need to start medication. Patients will oftentimes notice their symptoms or those around them would notice their symptoms. But if it doesn't impact a patient's daily activity or their ability to engage with their family, their hobbies, to do their work, then that might not be the exact right time to start medication. It's when we find the detriment, when we find that the symptoms inhibits their ability to engage in those activities, that's when we start to consider starting medications. Things to consider when we start medication would be a patient's age, the severity of their symptoms, any comorbidities, and any other chronic disease states that they have, and any other medications that they take. And we always want to make sure that we don't have any drug-drug interactions that can put you at unnecessary harm. Any questions about this so far? Yes.
When should we stop medication?
When should we stop medication?
Yeah.
That is, sure. It depends on what you might be experiencing with those medications. If side effect profiles are too burdensome or too severe, we oftentimes have to make changes to the medications. We might try a different drug within the same drug class to see if we can avoid some side effects, or we might switch a drug class completely.
Michael, I'm going to ask you one from our online audience. First one, is there an upper level dose of levodopa before the risk of dyskinesia increases?
There's not a set maximum dosage. Again, for the online audience, the question is there a upper limit dosage of levodopa before dyskinesia can occur? Is that correct, Mike? Or increases. The risk of dyskinesia increases. Again, that risk of dyskinesia, and we'll talk about this in the motor fluctuations, but the risk of dyskinesia increases as Parkinson's disease progresses. What we call the therapeutic window shrinks over time, and the upper limit of that window is the risk of toxicity and side effects, and that can increase over time. But to answer the first portion of that question, is there a maximum dosage of levodopa? Not necessarily. We work with levodopa by increasing dosages, decreasing the interval between dosages to make sure we maintain a consistent level of dopaminergic stimulation in your body to give you relief of your symptoms. All right.
So starting a prescription, it's the call of the prescriber and the call of the doctor to say, I think we're ready to start. You'll just add everything up with your age and how long you've had it, more simply.
Sure. I would say it's a conversation between the prescriber, treating physician, and you as the patient. If you say to me, I don't necessarily feel like my symptoms inhibit any of my day-to-day activities, that might not be the right time to start medication. But through continued vigilance, continued monitoring as things change and progress, one day a patient might come and say, my tremor is inhibiting my ability to do my work. Then that conversation, turns a different page. Okay, so some of the questions I feel that this discussion on motor fluctuation is of great interest. And so what are motor fluctuations? Motor fluctuations are things such as wearing off, which is the reemergence of symptoms at the end of a dose, or it can be sudden and unpredictable. Or another characteristic of motor fluctuation is the delayed onset of the medication after taking it. Specifically, oftentimes we discuss levodopa, or what we call a dose failure. Basically, when we take levodopa, we don't feel like the medication has really kicked in at all. And so this graphic here, and again, quite busy, but we'll hone in on each detail and we'll walk through this very slowly, is a depiction of blood levels of levodopa through the spectrum of disease for Parkinson's. Here at the very top, as we move from left to right, we'll find the disease progression. So left being very mild, maybe earlier in the onset of Parkinson's diagnosis, to more moderate in the middle, and at the very end, severe fluctuations due to advanced Parkinson's disease. Okay, so we're moving chronologically from left to right, mild to severe. Next, on the left-hand side, represented by the squiggly line, you kind of see that wave pattern in the graphic. That represents the blood levels of levodopa. So when we take our levodopa, maybe in the beginning it's 1 tablet 3 times a day, maybe towards the end we have to make adjustments, and that graphic will tell us why. Okay, but it's represented by that wave line that you see in the middle. Here is what we call that upper threshold. When medications hit at a very high threshold, peak dosages, that's when we find the highest risk of toxicity, highest risk of side effects, in this case, represented by dyskinesia. Okay? Here at the bottom of the graph, in this blue shaded area, is the minimal effective level of medication. Anything below this level, we will see symptoms start to reappear. And so our goal as clinicians and as we monitor your development and changing to your medication, we want to aim for this middle level of the white space called on-time therapeutic window. So I'll walk through that again. So the upper threshold in that light blue shaded gray area is what you can consider a toxic level. The bottom blue shaded area is a minimum effective level. And so when we have a minimum effective level and a top boundary, toxicity, the space in between is what we call the therapeutic window. Does that make sense to everyone? Yeah, is everyone tracking with me? Okay, great. So as disease progresses from left to right, that window, as you see, shrinks. And we'll walk through an example. So say, for instance, one of our patients is represented by this red dot. What you find is that in the beginning, if we start medication, this patient lives in that therapeutic window for most of the time, right? That white space where they're getting good symptom relief, but we're avoiding the toxic level that causes side effects, such as dyskinesia. But then as things progress, that window starts to shrink, and that's a characteristic of Parkinson's itself. As the disease progresses, that window starts to shrink because there's a higher threshold for symptom relief and now a lower threshold for side effects and toxicity. And that is oftentimes where we come in as your care team, is that we start to monitor how these things progress and how they might change. And eventually, maybe more towards the middle of the disease progression, when we're more moderate, we get to this point. And this point is what we call motor fluctuations, is that you'll find that the medication doesn't last as long as it used to. You might have to move from 3 times a day dosing, maybe every 8 hours while you're awake, every 6 hours while you're awake, to more frequent dosages, maybe every 5 hours, 4 hours. And sometimes, at its most severe, every 2 hours, 1.5 hours. It's because of that shrinking window of opportunity, that therapeutic window. As it narrows, it gets harder and harder to maintain a consistent drug level for our patients, making the management of the symptoms more and more complicated. That's when we start to consider adjunctive medications, again, the medications that amplify levodopa in the body. We might start to, again, increase the dosage, decrease the interval between dosages. So that's what wearing off is. Now, on the other side of that is the delayed on. And delayed on is when you take a medication, it used to maybe kick in 15 minutes, and that's a great window. You take the medication 15 minutes later, you find symptom relief. As things progress, though, you might find it gets longer and longer. You have to wait 45, maybe an hour. Maybe it really doesn't really kick in anymore the way it used to. And that's when we start to consider, how are you taking the medication? Are you separating it between protein and meal times? Are there other medications that could be blocking the absorption of levodopa? And so these are the kind of the management tricks and things we'll go through with our patients to make sure that everything else being optimized, that we can address some of these absorption and these delayed on issues. Okay. So as we finally get towards the end of our disease progression, you really start to see that this window of opportunity, this therapeutic window, gets smaller and smaller. That's when we start considering different formulations, extended release formulations of our medications, other formulations of levodopa, such as the intestinal gel that gets infused through a pump, where we have to start thinking about rescue medications. And rescue medications are things you take when you feel that off time coming. You take the rescue medication and hopefully it bridges you over back to an on time next to your next dosage of levodopa. And so this is kind of why the management of motor symptoms gets really difficult towards the end of, or towards the more moderate and severe advanced Parkinson's. So again, how do we manage motor complications? For end of dose wearing off, we might shorten the interval or take as needed doses of arsenamide. Addition of other medications, again, the things that we talked about, amplifying levodopa in the body, rescue medications. Sudden or unpredictable off periods. Again, maybe a as needed pill in the pocket, take it when you need carbidopa, levodopa, or consider the levodopa inhalation or apomorphine. For delayed onset, we ensure medication is being given on an empty stomach, again, separating for protein. We might increase individual dosages just to make sure we're getting you to the minimum effective dose. And again, we might use a rescue medication as bridge therapy. For dyskinesia, we talked about this, is we might decrease the levodopa dose, decrease the dopaminergic load to avoid that side effect. We may add amantadine, again, amantadine, either the regular or long-acting version to treat the dyskinesia. And then dystonia, which is oftentimes a wearing off symptomology, we will target getting you back on, having those bridge doses, having those as needed carbidopa, levodopa. Or dystonia might occur while you're actually on your on period. Then we would have to consider decreasing the amount of levodopa that you get, consider the anticholinergic or amantadine. And lastly, if there's no clear pattern or if there's not a sense of when dystonia occurs, there's Botox injections to help treat those as well.
Difference between extended release and all release.
Are you referring to carbidopa, levodopa? So there is. The question for the audience was, is there a difference between extended release carbidopa, levodopa and controlled release carbidopa, levodopa? Extended release is under the brand name of Rytary, and its formulation is actually very interesting. It's different than the controlled release, and Rytary is formulated as little beads of carbidopa, levodopa. Once that capsule dissolves in your stomach, those beads release the medication in different times and through different and hoping to extend the amount of medication you absorb longer. And so the aim of that is always to make sure we avoid peak levels that cause side effects, but also maintaining a consistent level in the blood. And so Rytary and the controlled release Sinemet, they are formulated different. Rytary has a more specific targeted approach. Yeah, nuanced approach. I'm sorry?
Probably shouldn't chew them.
I wouldn't recommend chewing them. No.
So have you ever had patients who or not really having diagnosis? Experience that.
I have, and oftentimes we find that they have maybe some slight difficulty differentiating between the two, but they may not have a dramatic on and off. It might just be a slight fluctuation in their symptoms, and so oftentimes we have to be able to tease out and characterize, what they're experiencing. Yes, Mike.
Another one we had from online was related to the dopamine agonist. There was knowing the risk of the side effects, and this came from the role of pharmacists. Is this something that pharmacists are or should be telling people when it's being tried?
So maybe rephrase the question a little bit.
And as far as the communication, is that something, those side effects, that is being typically
Okay.
communicated by the pharmacist, or how's that communication make sure that people truly are aware of what's the side
Sure.
effects?
Sure. So I think the question for the online audience is knowing the side effect profile of these different medications, do the pharmacists oftentimes discuss these medications in depth with our patients? I venture, and I can't speak for all pharmacists, especially pharmacists who are working in, I guess, more retail dispensary roles. Um, they may not. They may not. And it oftentimes is why we bring these up during these conversations so that our patients are aware of the severity of which these side effects can affect their life. And it's always worth a conversation. I always advise patients ask questions of your pharmacist, ask questions of your prescribers, and make sure that you're fully aware and advocate for yourself and for your care, so that you have the information that you need. Okay. Yes.
I've noticed that wearing off uh, the afternoons are a whole lot worse than it is when I get up and have over. So I'm wondering if medications aren't effective at some point, better off.
That is a question that we oftentimes face. The question for the online audience is oftentimes we find that the wearing off or the off periods are pretty significant in the morning when we've not had medication in our system overnight. And there are some patients
It's
less significant.
it's easier.
Okay. Okay. So my mistake that the off periods are less significant in the morning, easier in the morning. And that could be different for each patient. What I tell patients oftentimes is, especially those who don't have trouble getting up and getting going in the morning, if your symptoms don't inhibit you from starting your day, then perhaps you don't need to take your medication first thing in the morning. Perhaps you can time it so that when your symptoms start to worsen later in the morning, mid-morning, that you adjust the medication so that you see its peak effect, its most benefit when your symptoms are most troublesome. Okay, so we're gonna move to the non-medication approach. And I'm gonna turn on my notes here briefly, one moment. Okay. So in terms of medicate or non-medication approaches to the treatment of motor symptoms, exercise is one of the main tools, really the only tool thought to perhaps slow down the progression of Parkinson's disease. No medications or supplements have really proven effective in slowing progression of Parkinson's. Exercise really is the main thing we could perhaps point to some evidence that it can slow down the progression. We also employed the multidisciplinary approach. So beyond just perhaps your treating provider and maybe a nurse in the clinic or a pharmacist, we also incorporate physical therapy because physical therapy really helps with our balance and gait training. As those changes occur in Parkinson's, physical therapists, specifically those trained in Parkinson's, can help you come up with some adaptive tools for that change in your balance and gait. Speech therapists help with the dysphagia, which is the loss of the ability to swallow without aspirating, and with speech and with cognition. Occupational therapists can help with dexterity in your fingers, adaptive equipment in your home and home safety, and a driving evaluation to make sure you're not at undue risk of any accidents. And then, of course, a social worker to help care for the caregivers, to give support to the caregivers, and to give resources. And all of this and all of these teams should be utilized throughout the spectrum of Parkinson's disease because your needs change from each stage to the next. And you want to be able to establish care with these different groups so that you're getting the most holistic treatment that you can. There are surgical options to treat motor fluctuations, mainly deep brain stimulation and focused ultrasound. I'm not going to go too much into detail as this is kind of above my pay grade and over my head, but fascinating surgical options out there. And then we do have a lot of interest from patients regarding complementary therapies. One of them being cannabinoids, so CBD. And CBD, there's only been really 4 kind of good studies out there with CBD and Parkinson's disease and how if they might provide benefit in motor symptoms. And the jury's still out. It's been some conflicting evidence, not a lot of benefit found in these 4 studies. However, there's still a lot of interest in the study of CBD use in Parkinson's disease, more to be found with further studies. There's also been some interest in the use of vitamin E and C as their antioxidant properties might be able to prevent the breakdown of dopamine neurons in the brain. But again, for a lot of these, if not most of these complementary therapies, the evidence is just not robust enough where we can suggest their use. Yes, sir. Not really. In terms of things in the multivitamin, there's not anything that's too much of a concern. What we'll say with some of these vitamin boosts or taking supplements is that as part of a normal health maintenance, if you are low on vitamin C or low on vitamin E, then taking a vitamin E or C supplement based upon your direction of your treating physician is absolutely fine. But we just can't recommend specifically for the treatment of Parkinson's motor symptoms the use of these vitamins and these therapies.
So I thought I heard and read that taking magnesium.
I may not be too familiar with that or heard the same.
Somebody said no.
Yeah, I'm not familiar with that,
Oh.
unfortunately. Okay, so I'll kind of wrap up and end here. There's no use in talking to a pharmacist if he doesn't provide you with some practical tips and tools. And this goes beyond Parkinson's and to really just overall health maintenance and medication management. I always end on these tools so that patients can be prepared for any situation they might find themselves in. So my first pearl is this, is always carry an up-to-date medication list. And this list should include the name of the medication, the strength of the tablet, pill, or otherwise, and the dosage that you take, so say 2 tablets, 3 tablets, 4 tablets. The strength being 25 milligrams or 100 milligrams, things like that. Yeah. And then
Not referring to the doctor.
and then the time of which you take the medication, if you have specific times. For some patients, carbidopa, levodopa, they have to take it at certain intervals. They've come to recognize a schedule for themselves and a routine. And then the prescriber, and if you have a preferred manufacturer, some patients find that they prefer one manufacturer over the other, mostly due to the ancillary ingredients within the medication that they find they react to poorly. And so if you have a preferred manufacturer, make sure to have that listed. And of course, the pharmacy in which you obtain your medications. My next pearl is this, is a symptom and medication diary. Because unfortunately we can't be at home with you to see how your symptoms react based upon when you take your medication, we are reliant upon the patients and their caregivers and your report. And so oftentimes patients find it difficult to remember, oh, it worked this way that one day and a different way that other day. And so what we suggest oftentimes is to keep a symptom diary. So when did your symptoms start in the mornings? Say an hour after you wake up. After you take your carbidopa, levodopa, or your medication, how long before you find relief to your symptoms? How long does it take for them to kick in? And then how long does it last? Does it last all 8, 6, 4, 3 hours? Or do you find that it starts to drop off before your next dosage? And then what side effects are you experiencing? When do they occur? Do they occur shortly after you take the medication? Maybe further towards the next dosage of your medication? And this will help us to manage and to adapt and to be nimble as we modify medications for you. So in summary, we've gone through quite a bit, probably underrepresented by these 3 bullet points. But the decision on starting medications should be individualized. Again, the treatment course is also very personal between the patient and the treating provider. Motor complications of therapy requires that balancing act of providing symptom relief and avoiding side effects, complicated by the fact that that window shrinks over time in the disease progression. There are many non-medication approaches, and referral to support care teams are important throughout the progression of the disease. And so with that, I want to thank you for your time, and I do want to give a specific thank you. We do have a special guest with us here in the studio today. My mother is visiting from Taiwan overseas, and she's been visiting with me for the last couple of weeks. And if you could just give her a warm welcome, thank you so much. Yeah. With that, thank you so much.